So we're going to talk about treatment of dementia. And when I was first putting this talk together, I thought what I would do is come up here and sort of bemoan the fact that we haven't gotten very far with treatment of dementia. But as I was looking up slides and looking up data for this talk, I kind of changed my mind. And I think what we're going to talk about more is sort of encouraging people to use the treatments that are available. They're not the treatments we would want, but they are the treatments we have, and they do work in the way that they're claimed to work. So unfortunately, I have no disclosures. The current state of treatment of dementia is largely driven by Alzheimer's disease. It's the 800-pound gorilla of dementia, right? Alzheimer's disease is far more common than the others. It's far more well recognized than the others. We have no disease-modifying agents. We do have some strategies that are thought to reduce the risk of developing Alzheimer and other dementias, but we're not sure yet because there are no really good prospective studies. Most of the treatments that have been developed for dementia have been developed for cognitive symptoms, which is good, but if you look, you'll realize that behavioral symptoms, depression, apathy, and so forth, actually drive a lot more of the disability, caregiver distress, and patient distress than do the cognitive symptoms. And the final sort of downer, this is a slide of downers, is that there have been no new medicines for almost 10 years. Since the introduction of Namenda in 2003, I think, there have been no new medications to treat Alzheimer's disease, and there have been no medications at all to treat other dementias. So the cholinesterase inhibitors, like Alzheimer's disease, the cholinesterase inhibitors are the 800-pound gorilla of dementia treatment. The idea is that in Alzheimer's there is a cholinergic deficit. There's less acetylcholine in the cerebral cortex. There's loss of cholinergic cells in the nucleus basalis of Maynard. And as a result, there's decreased acetylcholine transmission. So the idea is, if we can block the breakdown of acetylcholine by blocking cholinesterases, we'll get more acetylcholine, and voila, we'll have a perfect patient. The cholinesterase inhibitors, the three that are in common use, are listed here. Tacrin was actually the first, but it is now in the dustbin of medical history because of its hepatic toxicity. But the ones that are available still are donepezil, brand name Aricept, approved by the FDA for treatment of mild, moderate, and severe AD. And it comes in a tablet, an extended release 23 milligram tablet, as well as a dissolving tablet. There is Exelon or rivastigmine, which is approved for mild and moderate Alzheimer's and Parkinson dementia. And there's galantamine or Razidine, which is FDA approved for mild and moderate Alzheimer dementia. So one good thing about these medicines is that we have lots of experience with them. We've got 20 years of clinical experience. We have independent studies, which are often hard to come by with newer medications. And overall, what they show is that in most people, they do have some effect. Again, not the effect we would want, but some effect. And the effect is generally described as a delay in the decline, a delay in symptomatic progression. And that delay is somewhere on the order of 6 to 9 months, and it occurs in most people who take the medications. In about 1 in 4 people, there's actually some improvement cognitively. Small improvement, but some improvement nevertheless, which is completely the opposite of the natural course of the disease. And a key factor in these medicines is that not only is there improvement in cognition, but there's also improvement in global functioning, which is made up partially of activities of daily living and performance in behavior. So here's just an example of, or a few examples actually, of studies looking at cholinesterase inhibitors. So this one is a study of rivastigmine, and they're looking at the ADAS-Cog, the cognitive portion of an Alzheimer's evaluation scale. And up to the 26-week point, you just have people who are on rivastigmine versus people who are on placebo. And as you can see, the blue line, the people who are on rivastigmine, separate pretty early and pretty clearly from those who are on placebo. At week 26, the people who are on placebo are now given rivastigmine. And you'll see there's a little bit of a spike, a little bit of improvement in their trajectory. But the two main points that I want to make here are that the people who get the rivastigmine later never catch up to the people who got it at the beginning of the study. And also, as you can see toward the end of the study, the decline does continue downward. So the decline parallels that of people who didn't receive medication, but it never really gets as bad. This is another study looking at galantamine, and I think actually the negatives here should be on the bottom. But this is MMSE scores. 2 doses of galantamine, 24 and 32 milligrams. The 24 is the maximum FDA recommended dose. And you can see again early significant separation from placebo, which is the pink line, in both doses. Another important aspect of the use of cholinesterase inhibitors is that they are helpful with behavior. So this is a study looking at donepezil, and they're looking at different aspects of behavior as measured by the Neuropsychiatric Inventory, or NPI. And the red are the people who are treated with donepezil. The gray are the subjects who were on placebo. And improvement is the bar going upward. And you can see that in just about every domain, there's a trend towards improvement with the donepezil as opposed to the placebo. And in fact, in depression, anxiety, and apathy, there's a significant difference in the degree of benefit that's gained with donepezil versus placebo. So they don't only have cognitive benefits, they also seem to have some behavioral benefits as well. This is another study looking at brain metabolism. So we have 2 groups of patients here, and each of them is measured at baseline and then measured 12 months later. This slide's not in your booklets, I just threw it in to confuse you. On the left are patients who are not receiving any cognitive enhancer, and the direction of the arrows shows the way that their brain metabolism, as measured by FDG PET, progressed over the year. And you can see that in frontal and cingulate areas, there's a marked decrease, and all those asterisks mean significant decrease in brain metabolism in those areas. On the right is the group that was treated with rivastigmine, and for the most part, they maintained pretty stable brain metabolism. And actually, in part of the frontal lobes, they had an increase in brain metabolism. What that means, change in brain metabolism up and down, is not clear, but they did find in this study that preserved metabolism was associated with improved performance on free recall, word recognition, and digit symbol. So there's an association between whatever these medicines are actually doing in the brain and people's performance on cognitive tests. Another study looking at brain metabolism, this looked at both cognition and behavior. So these are individuals who are on galantamine. Everyone in this study was started on galantamine. And what they compared was people who had a response, in other words, showed some improvement on testing, versus people who did not respond. And what they found was that people who had improvement cognitively seemed to have improved metabolism in the left cingulate cortex. People who had less depression had improvement in right cingulate cortex. And apathy, people who had less apathy at the end of the study seemed to have improved metabolism in the ventral pallidum on the right. Those are all reasonable locations to expect these symptomatic changes, and again suggests that these medicines are doing something in the brain, and that something is associated with a better outcome. Of course, every silver lining, no matter how small, has a cloud, and cholinesterase inhibitors have their side effects. So there's some that are obviously cholinergic side effects, including stomach upset, most commonly expressed as frequent stool or loose stool, nausea, sometimes frank vomiting, bradycardia because of the cholinergic influence on the heart, and in fact bradycardia is a contraindication for the use of cholinesterase inhibitors, and increased respiratory secretions, so increased mucus production in the respiratory tract. And then there are other effects that are probably cholinergic, but it's unclear. They're not as obviously cholinergic. Anorexia and weight loss is not uncommon with these medications. Sleep disturbances are pretty common. Drowsiness can occur in some people. Some people can't sleep if they take the medicine at night. And sometimes you can get paradoxical behavioral changes, particularly in people with non-Alzheimer dementias. And nightmares are also a frequent complaint that I've heard. There's no a priori reason for choosing one of the cholinesterase inhibitors versus another. Most of the reasoning behind the choice is based on the individual patient, often based on the individual patient's insurance company and their preferences. Galantamine, for example, has to be twice a day unless you take the extended release version. Same thing with ribostigmine, has to be twice a day unless you use the patch. There are benefits even in advanced Alzheimer's disease, and we'll talk about that a little bit later. The benefits do seem to persist. So one trend that I've been hearing from patients is they're being told that it doesn't make sense for them to continue the medicines because at some point they stop doing anything. And I think that's not exactly the case, and I'll show you a little evidence to support my view on that. There is no effect on the underlying disease. So you get these temporary changes in symptoms, these changes in brain metabolism, but there isn't any change in the cell death, the accumulation of amyloid and tau. And most data suggests that you want to start as soon as you know that the patient has dementia, and you want to aim for the highest dose that they can tolerate, or the highest dose that's recommended by the FDA. There's another drug on the market approved for dementia, for Alzheimer dementia specifically, and that's Memantine, or Namenda. And this is approved for moderate to severe Alzheimer disease. And it comes basically in 5 and 10 milligram tablets. The 5 milligram tablets are usually used in titrating the patient to 10 milligrams twice a day over 4 weeks. Memantine is usually pretty well tolerated, but some of the side effects that you will hear are headaches, grogginess, and dizziness. And it was marketed to be used with the other agents, although it probably has benefit when used alone. So this is looking at Namenda with the severe impairment battery, which is a sort of a combined test of cognition and behavior that's used in people who are a little bit more advanced. So these are moderate to severe Alzheimer's patients, and you can see a similar pattern to what we saw with the cholinesterase inhibitors. Early separation from placebo, that separation from placebo is maintained. This particular study was only 24 weeks. Memantine also has effects on brain metabolism, again in a similar fashion to what we saw with the cholinesterase inhibitors. Memantine seems to increase FDG uptake on the PET in the parieto-temporal regions and in the inferior temporal regions. And that increased FDG uptake, or increased metabolism, is associated with improvement on the neurobehavioral rating scale. This is the slide I alluded to earlier. So this is a bit of a complex study, but not too bad. This is in a group of patients with moderate to severe Alzheimer's disease, about 300 patients. Most of them had severe Alzheimer's disease, so that's a mini mental state between 5 and 9. And most of them had been on donepezil for at least 3 years. So this is sort of the group that I think we often get the question, what good do these medications do? So patients who are advanced, patients who have been on donepezil for a long time. How well can you pick up the colors in the back? Can you see the 4 different colors? Okay. So the most important distinction here is between the orange line, which is people who were on donepezil for 3 years, and then it was discontinued. They were just put on placebo tablets. The other lines, the green is people who were on donepezil for 3 years, or were on donepezil and then Memantine was added. The yellow, they're on donepezil and just a placebo was added. And then the blue, they were switched from donepezil to Memantine. When you look at the 3 treatment arms, the blue, yellow, and green, you can see that they end up at pretty close to the same place. Close to a wash. There's a little bit of an advantage for adding the Memantine to the donepezil. But there's a very big difference between those arms and the arm that went to placebo only. This is on the MMSE, so this is a cognitive test, but we see a similar issue with activities of daily living, where in this case, increase is doing worse. So again, the orange arm, which is people who got switched to placebo only from donepezil, did considerably worse than any of the treatment arms, whether it was continuing donepezil, switching to memantine, or taking both donepezil and memantine. And again, there's a little bit of an advantage here for donepezil plus memantine over either one alone. Again, this is people who've been treated for a long time who have advanced disease, 55% of them, MMSEs between 5 and 9. So again, you want to treat people as soon as you know they're ill and treat them with high doses. There does not seem to be evidence for efficacy of cholinesterase inhibitors in mild cognitive impairment. There's perhaps a special case in people who have depression and mild cognitive impairment, not progressing to Alzheimer's as often if they're treated with cholinesterase inhibitors. There does not seem to be any evidence for memantine's efficacy in either mild cognitive impairment or in early Alzheimer's disease, although clearly in moderate and severe Alzheimer's disease there's benefit. And combined treatment is safe and appears to be effective. I'm just going to touch a little bit on other dementias because these medicines can be used to treat dementias other than Alzheimer's disease. So dementia with Lewy bodies, which can include Parkinson's disease dementia or dementia with Lewy bodies. In both of those, there is a marked cholinergic deficit. In some estimates, bigger cholinergic deficit than what we see in Alzheimer's disease. And so the same reasoning that applies to using cholinesterase inhibitors in Alzheimer's disease applies perhaps even more so to using them in these conditions. Rivastigmine, as I mentioned, is approved for treatment of Parkinson's disease dementia. When studied in these diseases, cholinesterase inhibitors do seem to slow the progression of cognitive symptoms. They also seem to be particularly beneficial behaviorally for hallucinations, which are a big problem in both Parkinson's dementia and dementia with Lewy bodies. And then overall quality of life is improved when they are treated with memantine as opposed to placebo. For vascular dementia, the data are a little bit more mixed, but there actually are several studies that do favor the use of cholinesterase inhibitors in vascular dementia, and there are also several studies that demonstrate cholinergic deficits in vascular dementia, so that does make sense. Frontotemporal dementia is a little bit of a different picture. Cholinesterase inhibitors seem to have a tendency to cause worsening of behavior in these patients, which makes sense because there is not a significant cholinergic deficit in FTD. Memantine, however, might be beneficial for behavior, reducing things like irritability, impulsivity, and agitation. It does not seem to slow down the progression of cognitive symptoms of frontotemporal dementia. We come to medical foods, which are not drugs, but they are available by prescription. And they are indicated to treat metabolic conditions. They don't have to demonstrate a clinical benefit, but there have been some demonstration of clinical benefit. So the two that we generally use in Alzheimer's disease are cerefolin, which is a combination of pyridoxine, cyanocobalamin, and folate, and it's indicated for hyperhomocystinemia. There are some data that suggest that this combination of B vitamins reduces the rate of brain atrophy in people with mild cognitive impairment. And then there is Caprylidene or Axona, which is a blend of triglycerides. It increases ketone bodies in the plasma and is thought to increase the energy supply to the brain. So this is Caprylidene on the ADAS-Cog. You can see there's less decline. Our people who were on Caprylidene stayed pretty stable. This is only over 3 months, so that has to be interpreted with some caution. And then another study looking at the ADAS-Cog with Caprylidene, or Axona is the brand name, where again, the individuals who are on the drug are maintained cognitively as compared to those who are on placebo. We should talk about psychotropics in dementia because, as I said before, behavioral problems are a key feature of the dementias and also contribute more to psychological distress and disability in dementia than do cognitive symptoms for many folks. There are no medications that are approved by the FDA for treatment of behavioral symptoms in dementias. However, they are widely used. So Tacrin can be used for dementia. How many of you have someone on Tacrin? Okay. How many of you have someone on an antidepressant with Alzheimer's disease? How many of you have someone on an antipsychotic with Alzheimer's disease? Okay. So you can see that, the FDA says things, we do things, they don't always match. So they are commonly used. However, they do have some problems in dementia. They can cause paradoxical agitation. So agitation is one of the most common indications for which we use psychotropics in dementia. But some of the psychotropics, and you can't pick which one it's going to be in a given patient, some of them can cause agitation even though that's what you're trying to treat. Disorientation and confusion can also result from these medications in much higher frequency than those symptoms occur in people without dementia. So antidepressants are very commonly used in dementia. There are studies that don't seem to show any benefit of drug versus placebo when treating depression and Alzheimer's disease. My reading, and I think the reading of others, is that part of the reason for this is that there is a pretty large placebo response in these studies. And it may indicate that depression and Alzheimer's disease is sort of a fluctuating phenomenon where it can come and go within the space of months, and maybe in some of these patients it's not as persistent as we would expect it to be, and therefore in a 3-month study you won't necessarily pick up a difference between placebo and a drug that's working. There are some studies, though, that show that citalopram and sertraline, those are Celexa and Zoloft, do have some superiority over placebo, particularly, though, for agitation as opposed to depression so much. Therapeutic targets for the antidepressants include depression, of course, and anxiety, of course, but they also seem to have some benefit in treating agitation. As a matter of fact, a fairly recent study showed that citalopram is about as effective or more effective than risperidone in treating agitation. And sleep disturbances are another area where you can use antidepressants to good effect. Antipsychotics in dementia do seem to be efficacious in treating psychosis, of course, and agitation. However, they have to be used with caution. The FDA has put on all the labels of antipsychotics that there is an increased risk of death, of sudden death. The risk goes from 2.5% per year up to 4.6% per year. So it's not a huge amount, but it is a pretty big rise. It's almost a doubling of the incidence of these events. There's increased risk of stroke with the atypical antipsychotics, and it seems that the longer patients are exposed to these drugs, the higher the risk. So you want to use these medications briefly and at the lowest doses possible, and after other options have been exhausted, and that would include the antidepressants. Other psychotropics that can be used, anxiolytics, mostly benzodiazepines, can be used short-term for agitation that seems to be from a predictable environmental event that you know will be over soon. They, of course, have their side effects of increased agitation, paradoxically, but also confusion and falling, which you would expect from a benzodiazepine in someone with dementia. Hypnotics are often used in Alzheimer's disease because sleep disturbance is a pretty common phenomenon in Alzheimer's. I tend to use sedating antidepressants, particularly trazodone, sometimes mirtazapine. And the non-benzodiazepine agents I don't use as much because I think that they can promote quite a bit of confusion at night. They do that in normal people, and I've found that they are quite troublesome in people with dementia. So supplements and vitamins are very widely used by patients. There's really not a lot of data to support their use, but for most of them, they aren't likely to be harmful. There might be a beneficial effect from antioxidants, mostly in terms of prevention. When antioxidants have been studied in a prospective fashion in people who are already impaired, the results have been mixed at best. However, there's lots of retrospective data that suggests that people who have high antioxidant diets, people even who ingest exogenous antioxidants, may do better in terms of their risk of getting dementia eventually. And then we have to remember also that medicines aren't the only tools that we have. Physical exercise seems to have a host of benefits, including in cognition, in behavior, and of course in the patient's overall health status. Cognitive exercises may be of benefit. There was a recent study that suggested that crossword puzzles, specifically in comparison to other things, have some cognitive benefit. Most of the studies up until that one just showed that any cognitive exercise is good. It's probably good to help with behavior, probably good to help with cognition. And keeping the patient socialized is very important as well, making sure that they are interacting with other people and not just a minimal group, such as family. So daycare programs and things like that, you definitely want to get them involved in if possible. It's also important to treat caregivers because they are suffering as well. Here, for example, we do individual education of caregivers. We have lectures. We also do support groups. And remember that respite care is something that can be brought up to the caregiver who seems to be frustrated. A temporary period where the patient can be taken care of and the caregiver gets a bit of a break. There aren't huge amounts of controlled data on these interventions, but I will say that my experience working here for the past couple of years with the caregiver services that we have has made a dramatic impact in the lives of some patients and their caregivers. And remember that patients are very sensitive to caregiver distress. So if you do want to do the best for your patient, reducing caregiver distress is an important component of that. And you want to consider the benefit to harm balance. I recommended daycare to a patient, and the caregiver came back a few months later and said they're getting her to daycare every day no matter how much she fights and screams and cries. And at that point, I said, well, maybe it doesn't have to be every day. But there are situations where even what you would want to do ideally is not ideal for the relationship between that patient and that caregiver and may not be ideal for that patient because it may increase their level of distress. So I think we have a fairly hopeful future, actually, in terms of treatment of dementia. There are a lot of drugs, probably about 100 drugs, that are in clinical trials right now. And they sort of span the range of the things that you would want to do for people with dementia. So transmitter manipulation would be most likely, I think, to produce symptomatic benefit, probably not a lot in terms of disease-modifying effect. Drugs that work against amyloid and tau, we would expect a disease modification as we would with regeneration. Things that help cells to grow back. And then cell metabolism changes there could induce either symptomatic changes or disease-modifying changes. However, there's quite a while that we have before any new drugs will come on the market, and so we have to use the ones that we have the best way we can. That means making sure we have our patients started early, that we keep them on the medications, that we use the highest doses they can tolerate. The advent of amyloid and tau imaging is critical because it will allow us to detect disease before patients become symptomatic, which means we can treat them before they develop symptoms. It also gives us the ability to measure whether the disease-modifying treatments that are in the pipeline are actually having the effect that we want them to have. And I think there's going to be a lot more work on lifestyle factors because there's lots of retrospective evidence that people who exercise, who maintain good diets, who maintain good health habits do well, particularly in terms of things that protect the vascular system. But we do need prospective studies, and those are obviously hard to do when you're talking about overall lifestyle issues. This last slide is just to remind us that again, treatment is not just medication. It also involves the exercise that we talked about, non-pharmacologic treatment, but remember that clinical trials are also an important option. This allows patients potential exposure to something that may not hit the market until after they're dead. And so I would encourage everyone who has patients to send them for clinical trials because it does give us treatment options that we don't already have. And although our treatments do something, clearly the treatments that are coming down the road should do a lot more. Thank you.